I wish a very good evening to all of you. I'll start this topic, which is quite a bit difficult to understand in the initial phases, but it's a topic which is very important because many times we come across such patients. And we'll start this topic with tributes to the great man, the Prosper Meniere, because of whom we know about this disease. He was there in 1799 to 1862, and with tributes to him, I'll start the topic now. Now, before I go into details of the topic, I'd like to tell you that I will be dividing the topics into the history as such, because you should know and pay due respect to people who have already contributed in our history and who has given us knowledge of this particular diseases. The definition as such of the Meniere's disease, this understanding is very important because unless we know the definition of the Meniere's disease, the chances that we might misdiagnose a patient. Then, as usual, we go through epidemiology, the anatomy and physiology, which you already, I hope you are well versed with, the etiopathogenesis of the disease as such. Then we'll go into details of the classification, variants of it, and clinical features, and the differential diagnosis. The rest of it will, I think, will rather split it up into two parts, and in the next week we'll discuss about those parts, okay, regarding the investigation and treatment of that, rather the management of it. Now, by definition, what is Meniere's disease? Now, it's a disease of the membranous inner ear, which is characterized by spontaneous attacks of vertigo, with associated fluctuating sensory neural hearing loss, tinnitus, and oral fullness. Now, remember, each and every word of this definition is important. It is a disease definitely of the inner ear, that too of the membranous inner ear, and which is typically characterized by attacks of vertigo, which are spontaneous without any incubating or inciting factors. And usually and always, rather, it is associated with deafness, and that too particular sensory neural deafness. And the interesting or the very nice part of this is it is very fluctuating, which helps us in diagnosing this particular disease. It's fluctuating. So in between the attacks, the patient might be hearing normally, but during the attack and after the attack for a few days or few weeks, the sensory hearing loss can be clearly demonstrated. Patient will also complain of tinnitus and oral fullness. We'll go into details of each symptoms later on in the further slides. Now, as I told you, we'll start with the history. With the due regards to Prosper Meniere, who in 1861, who described the symptomology of Meniere's disease. Now, what was there before 1861 rather, in 1860s and before, whatever the patient were there of vertigo or any rotatory sensation or imbalance, they used to say it is because of central causes. Nobody was aware that this peripheral vertigo is a concept which is there and which can cause this particular debilitating disorder and cause serious problems. And he was a person who clearly defined the peripheral vertigo as such, the Meniere's disease. And the much more better understanding was given by Knapp, who gave an apt description of it. It's like it is something similar like glaucoma. This was in 1871. That is the inner ear hydrops, which is similar to glaucoma. That is increased pressure within the inner ear cavity. Or we'll go into details of that particular part later on. Then I had to take the name of George Portman, who proposed the surgical drainage of enterohepatic sac in 1926. And this is a chronological order that I'm giving the tributes. And then 1930, Dandy, who proposed the selective vestibular nerve section. In 1938, Halbach and Krenz, upon historical examination, confirmed the enterohepatic hydrops. Nothing but the enlargement of the enterohepatic sac as such. And Shuknet in 1957, we cannot forget his work. He has done extensive work in temporal bone dissections, and not only that, but he has done a clear-cut histological study of the temporal bone in various diseases. And apart from various other diseases, in Meniere's disease also, he has demonstrated the inner ear histology that nobody had done before this. And with regards to Fix in 1964, described the sacculotomy operation. Of course, nowadays we don't do this operation. And then we come to the epidemiology. The incidence of this disease is quite difficult to say because, as such, this particular disease many times, if it presents to say a primary care center or a novice ENT surgeon, then it might be overdiagnosed because it has to be a clear-cut diagnosis has to be there, and the many other diseases are there which are overlapping, and the chance of misdiagnosis are more. So the precise incidence is not known, but many books have mentioned the incidence around 15 to 30, almost 15 to 30 per 100,000 population, and prevalence is around 200 per 100,000 population. Now, majority of the standard books say that it is equal in both sexes, but OCNA typically says it is more common in females. So if they say it is more common in females, it is just a minor, say you can more incidence in females, that is 1.3:1. The age and onset of the symptoms are variable, right from third decade to sixth decade. Even in children, that has been described, but very rare below 10 years of age. But up to 14 years also they have been described. And most of the time, the disease is usually unilateral. But if you go histologically nowadays, what the recent Corbin mentioned is the disease is bilateral but presents unilateral, and later on after a decade or two, the other ear also presents itself. It is familial in 10% of the cases. Now, before we go into the details of the disease, I'll just brush up the memory or your knowledge about the anatomy of the inner ear. We know in the inner ear is made of three parts: the cochlea as such, the vestibule, and the semicircular canals. Now, in the semicircular canals, we have the superior, the posterior, and lateral semicircular canal. They open up into the saccule as such. The vestibule, which is made up of the utricle and the saccule. Saccule is in the this anterior part of the inner ear, and utricle is posteriorly, where all the ampullary ends of the semicircular canals open up. All means the superior and posterior semicircular canals are going to combine together and cause crus come in and open it. So there are going to be not 6 but other 5 openings in the utricle. And of course, last but not the least is the cochlea, which is the hearing organ, and it has got again divided into the 3 parts: the scala vestibula, the scala media, and the scala tympani. This is in short about the inner ear. We know the structures, and of course middle ear we will not go into detail because this is not concerning our topic as of now today. And the other important thing is see the proximity of the footplate of the stapes with the saccule. Now whenever I will come to that, one more good picture I am having. When the saccule is enlarged, it comes in relation to this footplate of stapes, and that can cause very many other clinical symptoms which we will be discussing. Now this is the section through the inner ear, which is showing clearly the osseous spiral lamina with the basilar membrane, the resinous membrane here, the scala vestibula, the scala media, which is having the inner ear as such, and the scala tympani. Over here we have got the organ of Corti and the basilar membrane. Oh, one more thing important I told you is, or forgot to tell you is the inner ear is inside the membranous labyrinth. We have got endolymph, and outside the membranous labyrinth is the perilymph. Now it is, in simple words, if you have to remember, perilymph is something like a CSF only. It is extracellular fluid, whereas the endolymph is something like an intracellular fluid as far as the composition is concerned. Now coming to physiology, the endolymph is located in the scala media, as I told you, and it is similar to composition of intracellular fluid. Typically, it has got high potassium content and low sodium content. The site of production is stria vascularis, which is there bonding the scala media. It is secreted typically by the dark vestibular cells, and absorption basically takes place in the endolymphatic sac and duct. So all these things are important because these are the ones which are going to cause that particular disease. Now coming to perilymph. In short, it is ultrafiltrate of cerebrospinal fluid through the perilymphatic capillaries. It is located in the scala vestibula and scala tympani. The composition is similar to the CSF, that is the cerebrospinal fluid. Typically, it has got high sodium and low potassium. pH is around 7.2, and absorption is via the perivascular spaces around spiral veins, loose vascular connective tissue around the endolymphatic sac. Now, these diagrams are very important. Again, we'll go to the pathophysiology of the Meniere's disease. Either there might be two possibilities. One is there is overproduction of the endolymph, or there might be reduced absorption of the endolymph. Now, this has to go on continuously for the cell to stay alive, in the sense the production of the endolymph, which is going to bathe the cells inside, and the inner ear cells, what I mean to say is the type 1 and hair cells particularly, and type 2 also. And this endolymph has to be absorbed also, which occurs in the endolymphatic sac. Whenever there is a mismatch between the two, that is overproduction or reduced absorption, that means the increase in endolymph, obviously there's going to be endolymphatic hypertension, or there will be bulging of the, or the swelling up of the endolymphatic sac and the endolymph as such in the spaces, that is scala media as such. There will be gross enlargement of the membranous labyrinth and endolymphatic hydrops. This is what is called as endolymphatic hydrops. Now these are the comparison between diagrams between the two. Now here you can see the normal inner ear. Now again I'll show you, this is the cochlea as such, this is the vestibule which has got the saccula, and these are the semicircular canals. Typically the endolymphatic duct is there, which is opening into endolymphatic sac, and this is the normal way how the inner ear looks. What has happened in the Meniere's disease? See the amount of bulging up that occurred. The vestibule has totally bulged up. The utricle and saccular totally bulged up, and the same thing has happened with the inner ear also. I'm sorry for disturbance. Now continuing with the pathophysiology. The enlargement of the endolymphatic volume will lead to a distension of the resinous membrane into the scala vestibuli. Eventually, the resinous membrane ruptures, and this typical ruptures is going to cause resultant leakage of potassium-rich endolymph into the perilymph, and this is what is actually going to cause the Meniere's attack. The mixing up of the fluids, the endolymph and the perilymph, is going to cause the endolymphatic, or the stimulation of the neurons there, and cause the attack, Meniere's attack. Now, typically, it has got the three phases. That is the initiative phase, irritative phase. That is increased concentration of the potassium around the basal surface of the hair cells, which is causes the initial excitation of the neurons, and causes the irritation there and excitation of the neurons, and thereby causing the sensation of rotation or the movement. It can be a vertical movement or a horizontal movement. It can be a floating sort of movement, or it can be a typical vertigo, like a rotatory sensation, either subjective, or if the patient is rotating around himself, or maybe the environment which is rotating around himself, or the particular patient as such. Then comes the paretic phase. This results from the blockade of the neurotransmitter release. The neurons are totally paretic, and the function is not restored normally, and this is the phase wherein the symptoms continue, though not in a severe way as in the irritative phase. And last is the restorative phase, wherein the healing of the rupture allows the restoration of normal chemical composition of the endolymph and perilymph. So the composition of the perilymph and endolymph is brought back to normal after the healing, and this is what will lead to the termination of the attack. Now, after the pathophysiology, we will come to the histopathological changes. This has already been told by me. There is a dilatation of the endolymphatic system. There will be bulging of the resinous membrane and herniation through the helicotrema. There will be marked dilatation of saccule, cochlea, and sometimes even the utricle. There will be scarring and resulting with the seal and previous ruptures. Ultimately, gradually, this is going to cause the gradual sensory hearing loss. Now, these are the typical, on this side where my arrow is pointing is the normal inner ear section, and here is the one with the Meniere's disease. You can see the bulging resinous membrane, which is almost at the point of rupture, whereas here it is normal. And this is the organ of Corti, where the organ of Corti is there. And you can see in each and every sections the resinous membrane is bulging. Now, this Meniere's symptom complex is the term that we should be better using it, because Meniere's disease is primarily a idiopathic disease, and it is called as primary endolymphatic hydrops, whereas Meniere's syndrome is secondary endolymphatic hydrops. That means there are some secondary causes which are going to cause the endolymphatic hydrops. Endolymphatic hydrops is nothing but what the pathophysiologists are told with the histology, that this sort of picture might be because of this secondary to some disease, or it can be primarily because of idiopathic cause or unknown cause of familial reasons. When it is idiopathic, then only we call it as typical Meniere's disease. Otherwise, it is Meniere's syndrome, not a disease. When you're using the terminology, you should be careful whether you're saying Meniere's disease or Meniere's syndrome. The etiological factors, as I told you, in Meniere's disease, 75% of the cases is idiopathic. Idiopathic means there are a lot of many other factors, like either the familial, then autoimmune, immune complex disorders, then post-infectious, post-traumatic disease. All this can cause to lead to Meniere's disease. Now we'll come to it one by one. The predisposing factors are the genetic, that is the familial, that is 10 to 20% of it. It is usually autosomal dominant, and possible locus is between HLA-C and HLA-A on the short arm of chromosome 6. And this has been demonstrated beyond that is one of the predisposing factors. The other predisposing factors are the anatomical. In many patients, there may be small vestibular aqueduct, which will lead to decreased absorption there, and reduction of volume of the rugose portion of the endolymphatic sac. Basically, the rugose portion of the endolymphatic sac is there. The rugose portion is there to increase the surface area, so that the absorption can be in a proper way and with a greater surface area. But if the rugose portion is less, then there will be reduction of the volume, and hence the absorption. Third is the traumatic. Many times the post-traumatic, either the physical trauma, say a road traffic accident or any other accident, or the fractures in the skull can lead to this particular condition, or can be acoustic trauma also. The other predisposing factors are the vasculopathy. Then vasculopathy in the form of either say the clogging of the vessels, either due to clots or the increased viscosity of the blood, or can be because of viral infections, say herpes simplex, enterovirus, or damage to endocrine sac and duct. Then even inflammatory and immunological dysfunction. It is also seen in post-infectious diseases like syphilis, trauma, and CSOM, which is long-standing. Then viral infections, I told you, like in herpes, otosclerosis, immune complex disorders, wherein the immune complex deposit themselves onto the membrane and cause the dysfunction of the membrane. Then abnormal fluid balance, leukemia, then Shire-Drager syndrome, abnormal metabolic and endocrine causes. So these are the causes of secondary endopneumotic heart drops, which is causing about 25%, whereas 75% are the typical Meniere's disease as such. Now we'll come to it one by one again. The syphilis is a Meniere's triad symptoms. It is congenital acquired, and there is a fibrotic obstruction of the sac. Here, basically, there is an obstruction of the sac because of fibrosis. In case of chronic suppurative otitis media, there is infectious products either in the form of toxins and enzymes. They affect the osteitis. They affect and infect the bone, and in bone infection is called as osteitis and mastocytitis, and release the endotoxins, which are quite harmful to the inner ear. Then coming to developmental insult, that is Montanus dysplasia. Other dysplasias who can cause it, like the Alexander dysplasia or Shebe's dysplasia or the Mitchell dysplasia. Then abnormal metabolic and endocrine status like hypo and hyperglycemia, hypolipoproteinemia, and hypothyroidism. Typically, it is many times seen in hypothyroid patients also. So it is mandatory that when you are investigating a patient of Meniere's disease or suspected Meniere's disease, then you will have to go. The patient has to undergo this battery of tests to rule out hypothyroidism and even the his blood sugar levels and the protein lipoproteins also. The continuing the etiological factors, the viral infection like the herpes infection can lead to delayed endolymphatic hair drops. Autoimmunity like Cogan syndrome. Cogan syndrome is nothing but it has got inner ear hearing loss along with this Meniere's type of syndrome with interstitial keratosis. Then otosclerosis, abnormal fluid balance. Other possible etiologies are leukemia, Shire-Drager syndrome, which is a multiple systemic disorder wherein the neurological components go on degenerating, then temporal arteritis. Clinical manifestations are the cardinal symptoms like episodic spontaneous vertigo, tinnitus, fluctuating hearing loss, and sense of fullness or pressure. The patient typically complains as if the ear is totally full with water or say some bulk of cotton pledge is placed inside the ear and the patient is not able to be comfortable there. The hearing loss is fluctuating as I told you, and vertigo is very spontaneous and it lasts say from 20 minutes to almost 1 hour also. This episode of vertigo is typically sudden spinning sensation. The patient feels as if there is no inciting factor. There is no factor which is going to elicit the vertigo suddenly, but without any say signs and symptoms, or without any premonitory symptoms, the patient will suddenly feels that there is a vertigo setting up, and the spinning sensation starts, and it's very severe, and patient will get debilitated. There might be diarrhea, cold sweat, pallor, and abdominal cramps. These are not related to actually our 8 now, but it is more of the vagal symptoms because the patient has a bit scared and anxious, and this will lead to all these particular symptoms like cramps and pallor and cold sweats. Aura prismatic attack is not typically seen with this Meniere's disease. The vertigo can be in the form of to and fro or up and down movement. This already I told you. And spontaneous emission between the attack. This is a very typical of Meniere's disease. So between the attack, the patient is completely normal. The patient will even forget that he even had that sort of vertigo. Of course, he will remember the vertigo is there, but he will forget the severity of it. There is something called a studio phenomena. This studio phenomena is nothing but a loud sound can cause or incite the sensation of vertigo. There will be typically no loss of consciousness, no focal neurological signs. This particular negative relevant history is very important because this will rule out the neurological causes of vertigo, even the hypertension or the transient ischemic attacks also. Because there is no loss of consciousness, patient is completely awake and conscious and knows what is going on and is debilitated and can tell you what sensation is undergoing, and the vertigo and rotation which is there. He is totally scared, has got cold sweats, has got abdominal cramps and pallor also. There are no local focal neurological signs like say paresthesias or any nerve palsies or any other neurological signs. The sensory hearing loss, coming to details of that, it is fluctuating and it's progressive. The hearing loss improves during remission and the hearing loss improves during remission. In the recurrent attacks, the improvement is not complete. So as I told you, the attacks are there, but in between the attacks, the patient becomes normal. Patient feels that is normal, but some amount of hearing loss persists. Say during the attack, if he has got around 60 to 70 decibel hearing loss, afterwards he becomes normal, but some around 10 to 15 decibel hearing loss, he keeps it with himself in the sense that persists there. And during this next and next attack, it will go on increasing, and later on will ultimately cause the total sensory hearing loss. Typically, it is initially in the lower frequencies, later on in the higher frequencies. There is disharmonic diplocosis. What is the meaning of disharmonic diplocosis? Now see what happens. One ear has got Meniere's disease, and because of this, the hearing, the inner ear hair cells are quite irritable, and they'll cause unnecessary excitation of the neurons at the sound, and whereas in the other ear it's absolutely normal. So a particular frequency hearing sound at a particular decibel will be heard abnormally in one ear and normal in the other ear. This will cause the brain to perceive it as a diplocosis. There is two sounds in place of one. This is disharmonic diplocosis, and typically there is intolerance to loud sound because the loud sound will cause. I'll come back to that picture if I will show you. Now see here, as I told you, whenever the saccule is very much enlarged, it will come towards the end of the foot plate of the stapes, and loud sound is going to cause the movement of stapes, which is normally it does, and is going to stimulate the scala vestibuli also, and ultimately this is going to lead to vertigo. So a loud sound is there, the patient ultimately gets vertigo. So he gets totally intolerant to loud sounds. I hope you are getting my point there. Okay. So there is intolerance to loud sounds. There's typical. These are the symptoms that you get here. Then coming to tinnitus, it is a variable character. It is roaring or rumbling. It is very typically low pitched, not pulsating like we see in glomus jugular. It is intermittent initially and continues later on. Typically during acute attacks is aggravated, and change in intensity and pitch may be the warning symptoms. And typically if you match the tinnitus as such with the audiometry, the area of the hair cells which are responsible for that particular frequency of sound are the one which are injured. So that is very typical of this Meniere's disease. Apart from the other symptoms like oral fullness, the obviously patient will have emotional upset, stress, and secondary agoraphobia. This agoraphobia is nothing but the fear of open spaces. This happens because patient knows anytime he might be having that particular episode of vertigo, and he's scared to go outside or in open spaces because if the vertigo starts, he knows he's totally debilitated and he'll not be able to walk and go around. So this agoraphobia is there, and many times it will may be the emotional upset is so severe that he might end up with either depression and even suicidal tendencies also. Now, after the symptoms are over, we'll come to the signs. If you do the routine examination of the ear, the external appearance of the ear, the external canal, all of them are normal, including the tympanic membrane also. You do otoscopy, that is absolutely normal. The tuning fork test, you do the Rinne's, Weber's, and the absolute bone conduction, you will come to know that there is sensory hearing loss. Typically, the Weber will lateralize to the affected ear. If you do the examination of nystagmus, there will be horizontal tremors, the irritative phase towards the affected ear. In the irritative phase, there are three phases I told you, that is the irritative, then the paralytic, and the recuperating or the recovery stage. In the irritative stage, the nystagmus is towards the affected ear. In the paralytic is towards the healthy ear, and recovery is again towards the affected ear. And it stays like that for hours together. And there's something called as Hennebert's sign. This is positive. Now, Hennebert's sign is nothing but if you typically give a recurrent pressure over the tragus and increase the pressure over the tympanic membrane, which will be transmitted to the through the ossicles to the inner ear, and since the inner ear, the saccule is enlarged and touching onto the foot plate of stapes, the vertigo will be elicited. This is typical Hennebert's sign. It is seen in congenital syphilis also. As a additional knowledge, you can tell it. I can tell it, and many times this has been asked in multiple choice sort of question and vivas also. Now comes the real part of it in a sense. How do we classify this disease? The complicated disease, because it is overlapping so many other diseases also. There have been some classification in 2015, but nobody has given the complete classification in the after 2015. In the sense, in the 2015 also, this what a classification I'm giving you is somewhere in 1995 it was given by the American Academy of Otolaryngologists and Head and Neck Surgeons. Meniere's disease is classified into definite Meniere's. When we call it definite Meniere's, we'll go one by one into each one of them. Definite Meniere's is a disease wherein there are 2 or more spontaneous episodes of vertigo lasting for 20 minutes or longer. So you take a history, there are 2 or more episodes of spontaneous vertigo, which is not been initiated by any particular stimulus, but this spontaneous vertigo, which is lasting for at least 20 minutes. Usually, typically, it starts for 20 minutes up to 1 hour also. It is associated with tinnitus or awfulness, and at least one time it should be documented with audiometry that there is a hearing loss in 3 consecutive frequencies. Typically, the 500 kilohertz, the 1K and 2K or 1.5K. Either 3 consecutive frequencies you have to check, and all these 3 frequencies there should be at least 30 decibel hearing loss, and it should be documented. That is when you call as definite Meniere's disease. Now, this certain Meniere's disease is only for theoretical purposes, because this will be definite Meniere's plus histopathological evidence or confirmation. Now, this is possible only after autopsy. So, this certain Meniere's disease is terminology which is only for theoretical purposes, because this is after the patient has ceased to survive. Then we come to this diagnosis after the postmortem and get that histopathological confirmation that there is a Meniere's disease. Now, possible Meniere's disease. Many times now these are the cases which you usually typically have encountered in our clinics and our outpatient departments. These are possible Meniere's. Here there is 2 or more than 2 spontaneous attack of vertigo even without auditory symptoms. So there may not be tinnitus, but we have excluded other causes. The other causes, when I'm talking about differential diagnosis, will come to the other causes, but all those other causes are excluded, and then we call it as possible Meniere's disease. Again, this we have to make it into definite Meniere's by doing either the audiometry at the time of or either in the period during when the episode is there, or immediately after the period of episode of vertigo, and document it properly to call it as a definite Meniere's disease. So again, I'll repeat: possible Meniere's disease, 2 or more than 2 spontaneous attacks of vertigo even without auditory symptoms, and other causes are excluded. Now comes the probable Meniere's disease. Here, 2 or more spontaneous attacks of vertigo is there with tinnitus or awfulness at the same time. Again, other causes are excluded. Audiometrically documented hearing loss at least on one occasion is there. So this is when we call it as probable Meniere's disease. So probable Meniere's disease is 2 or more than 2 spontaneous attacks of vertigo with tinnitus or oral fullness at the same time. And audiologically it has been documented that the hearing loss is present at least on one occasion. The other causes are excluded. Now these are the different types of Meniere's, but coming to the variants, like how they present to us, Meniere's disease may present in different ways, and as we know in medicine, 2 plus is not always 4. It can be 3 also, it can be 5 also. So in the same way, the symptoms might not always be the way you want it, but it can be in a way, any permutation combination. So in Meniere's disease, the variants are the cochlear head drops, wherein the head drops, the endolymphatic head drops is the typical of Meniere's disease. But in cochlear head drops, we get a deafness first. In vestibular head drops, we get the vertigo first. And this typical nomenclature is Tumarkin's autolytic crisis or drop attacks and Dermoid syndrome. I'll go in details of each one of them so that you'll understand better way. Now, cochlear head drops is there is sudden development of unilateral hearing loss and tinnitus. The cause is due to obstruction of the cochlear duct or isolated disorder of striovascularis. The striovascularis gets affected, and there is the disorder of the striovascularis, and then typically the patient will present with unilateral hearing loss along with tinnitus. Of course, the other cause has to be ruled out, and that is when the patients of cochlear head drops will present. The next is vestibular head drops, affecting the vestibular system as a result of defect in the uticulo-endolymphatic valve. There will be intermittent episodes of vertigo, and auditory function is normal. So typically, the cochlear head drops, you see there is no vertigo sensation, but hearing loss will be there. Whereas in vestibular head drops, the hearing is absolutely normal, but the patient will have vertigo only. Then comes the Lorry syndrome. It is nothing but reverse of Meniere's disease. In the sense, the occurrence of the events occur in the reverse order. This is a rare variation, but it is a frequent question in the exams. That much I can say. In either in the Viva or in the theory exam also. The symptoms occur in the reverse order. That is, there will be initially there will be a progressive deterioration hearing, which is then followed by vertigo. There might be history of migraine seen as per some books. Now again, 2 mark drop attacks, a favorite Viva question for many examiners. This is a sudden drop attack without loss of consciousness. The patient is completely conscious, and when he is walking or just standing, suddenly drops and falls to the ground without any reason, and that is the typical called as 2 mark drop attack. Now what causes this? There will be no vertigo, there is no fluctuation hearing loss. The patient gets a feeling of having been pushed to the ground. The patient, if you take the history, says that somebody just suddenly pushed him to the ground and has fallen. But that is not the situation, but that is what is the 2 mark drop attack is there. And the mechanism is there is a deformation of otolithic membrane of utricle sacule due to changes in the endorphic pressure. So this is a possible mechanism. There is a deformation of otolithic membrane of utricle and sacule due to changes in the endorphic pressure. This is called as 2 mark drop attacks. Now coming to the differential diagnosis. The vestibular disorders like peripheral and center, they can be broadly classified. The peripheral are the Meniere disease, which is very common. I mean, compared to other diseases. Then benign paroxysmal positional vertigo, vestibular pneumonitis, labyrinthitis, vestibular toxic drugs, head trauma, syphilis, acoustic neuroma, perilimb fistula. In center, we have the posterior inferior cerebral artery syndrome, then picarditis, then bacillar migraine, then cerebral diseases, multiple sclerosis, and epilepsy. So these are the various differential diagnoses. We have to deal through all this to rule out and come to the Meniere disease, which is a disease or the diagnosis of exclusion, because histopathology is not possible in area. Now, the conditions of vertigo without auditory symptoms are typically vestibular neuritis and benign paroxysmal positional vertigo. So if there are no auditory symptoms, there is like no tinnitus and there is no say hearing loss, then we have to think in terms of vestibular neuritis or BPPV, that is benign paroxysmal positional vertigo. This is how it is. I mean, we try to classify and make it into different groups so that it will be easier for you to come to any conclusion when you are taking a broad case of vertigo. Unless you filter on or focus on few things, it is difficult to reach a diagnosis. The conditions wherein the auditory symptoms are without vertigo, this is vestibular schwannoma. Now, what happens in vestibular? Of course, I'll come again to that later on. Then conditions is combination of auditory and symptoms in vertigo. So here both auditory symptoms, that is hearing loss and tinnitus, is there along with vertigo. This occurs typically in Cogan syndrome, then craniocervical dysplasia, and non-specific cochleovestibulopathies. Now, vestibular neuritis. This is a vertigo without auditory symptoms. So there won't be any hearing loss or any tinnitus. The vertigo is sudden in onset. The attack lasts for few days. It's not hours, but few days, up to 2 to 3 weeks. This is basically a typical infection, a viral infection of the vestibular ganglion, and the cochlear nerve is spared, and there will be no any hearing loss or tinnitus sort of symptoms. And it's a self-limiting disorder. So the treatment of this will be only symptomatic, and that will take care of the situation. Coming to the next diagnosis of the disease, wherein the only vertigo without hearing loss is the benign paroxysmal positional vertigo. Now this is entirely separate, complete a big topic, but in short we'll try to go through it so as to exclude it from Meniere's disease. Here the vertigo is without auditory symptoms. Vertigo is in certain head positions. So patient typically rise in a left lateral, right lateral, or the head is turned at 45 degrees or some particular position, and then vertigo starts. The patient knows at what position the vertigo, or if he puts the head in which position, and the vertigo is going to start. The latent period of few seconds, and after that the head movements. The last for less than 1 minute. This is very typical of benign paroxysmal positional vertigo. The hearing is unaffected, and nystagmus is fatigable. So if you examine the nystagmus, it is fatigable. Typically, there will be no hearing loss if you do tuning fork test, and this will not last more than 1 minute. It just for a few seconds and immediately stops. So it's very typical of BPPV, and it is basically benign disease. Nothing to worry about. Then coming to auditory symptoms without vertigo, these are next set of diseases, wherein there will be only auditory symptoms, but there will be no vertigo. Here we have to think about vestibular schwannoma. 5% of vestibular schwannoma, we should remember, present as Meniere's disease. There will be progressive unilateral hearing loss with tinnitus. Particularly, we have to think about cochlear hair drops. That different might confuse us with this vestibular schwannoma. Typically here the rotatory vertebra is absent, chronic disequilibrium is there, there will be neurological deficit, which is the point which can very much differentiate it from many other diseases, because neurological deficit, if it is there, it will totally rule out Meniere's disease. Second, the why their vertex is not present. Here the tumor, as you know, vestibular schwannoma is a tumor which is going to gradually slowly grow, and as it grows slowly, it is going to invade the structures on its immediate relations. It is going to um, rather press upon the cochlear nerve, wherein it causes hearing loss. It will press upon the vestibular nerve also, wherein the function of vestibular is lost. But the gradual progression of disease is so slow that typically the vestibular organs, which are bilaterally represented in the brain, the other one takes over the function, and sufficient time is there for the other vestibular organ to, which is normal and intact, to take over the function from the other side, and that's why the vertigo will not appear immediately, or it will not rather appear at all. The pure tone audiogram in vestibular schwannoma typically shows high frequency loss. This is again in contrast to our Meniere's disease, where there is a low frequency hearing loss. There will be absent recruitment, very poor discrimination. All these are the differentiating point from Meniere's disease, and there is absence of septal reflex or marked decay will be there. The tone decay, what I mean to say is. Now comes the real part, which is confusing. Here is the auditory symptoms with vertigo. Both the auditory symptoms like hair deafness and tinnitus are present along with vertigo. The Cogan syndrome, there is craniovestibular junction abnormalities, craniocervical dysplasia, combination of congenital and acquired bony vascular neural malformations. Example, high odontoid process, vertebrovascular insufficiency, focal neurological signs. This definitely needs further evaluation in the form of MRI or CT scan, and we can reach the particular diagnosis. And many times blood initials also. The non-specific cochlear vestibulopathies, then progressive, there will be non-fluctuating, usually unilateral hearing loss, there will be absence of fluctuations and low frequency loss. So this is in short about the differential learning that we have come across. If there are any questions or anything to be asked, you are free to ask, and we'll discuss about it. Or any part of the lecture if you have not understood.
Before we start the questions, good evening, Dr. Nitin. I'm Dr. Nilima this side.
Good evening, madam.
I welcome you on the platform, and thank you for a very comprehensive and a detailed presentation on the topic of Meniere's disease. And we'll take the questions shortly. If you can open the chat box.
Yeah, I just opened as Dr. Ramendra Kumar Singh. He's asking about treatment part. As I told you, I'll talk about the management. It becomes too big to be. This topic is so big that cannot be covered in say an hour also. In fact, even if you go 2 hours, it will be less. The treatment or the whole management part, that is investigations and treatment, will be covered in the next part. I think that is, tentatively posted in the next week itself. I hope that answers your question, Dr. Ramendra.
You can talk about the medical management, the surgical management.
Yeah,
it does require.
talking about it now, but what I was told was that it will be discussed again in the. I'll be giving the lecture on that on the next part of it. If you want me to continue, there's no problem at all. But it will take at least 40 minutes more or 35 minutes more at least. If you want me to start with that, no problem at all. So basically, the treatment of Meniere's disease will be in the form of either the disease is presenting in acute phase or chronic phase. Acute phase is basically we'll have to make the patient relax, give the labyrinthine sedatives. This in broad terms I'm telling. And later on in the chronic phase, we'll have to think about some modalities of treatment wherein we either the disease is either controllable or not controllable, and if it is not controllable, then we'll have to go in for some destructive surgery in the form of say labyrinthectomy or the vestibular neurectomy. And how it is to be done and what are the steps and all those, I think we'll discuss in the next, because it's a huge and big topic for that matter. Yeah, one of them is asking me the phases of I think from Manikala Rai is asking about the phases of Meniere's. Basically, there are 3 phases. I'll get that slide. It will be easier for you. Give me just a minute. I'll go to slide sorter and get to that particular slide. So you can note down also if it will be more easier for you people. Now this slide will explain completely the irritative phase, the paratic phase, and a restitution phase or recovery phase. Now, when we are talking about the pathophysiology, I told you that I'm not in the clinical features. The irritative phase is a phase wherein there is a rupture of the basilar membrane, sorry, the rupture of the resinous membrane, and the mixing of the endolymph and the perilymph. You know very well that the perilymph is like as of the CSF, and endolymph is nothing but the intracellular fluid sort of chemical composition. So potassium is high in the the endolymph, and perilymph the sodium is more. The mixing up will what it causes the sodium potassium pump. Which are there in cells, there is overtaken, and there will be mixing up, and there will be chemical imbalance there. The stimulation of neurons because of the potassium, which is the in concentration will decrease there, and the sodium will enter inside the endolymph and will cause the excitation of the neurons, and this will cause the irritative phase or the typical attack which suddenly starts. The varitic phase is results from blockade of once the neurotransmitters are released. After it gets excited, the neurotransmitters are released, and the nerve synapses are, in the sense, they are stimulated. And after that, there is a result of blockade of the neurotransmitter after it is released. This is a paratic phase, which gradually comes down, and then the recovery phase or restitution phase occurs, where there will be hearing of the resinous membrane, and again the reconstitution of the perilymph and endolymph will be there, wherein the chemical motion is brought back to normal, and ear starts functioning normally. And these are the three phases which again correlate very well with the clinical scenario. Okay, one more question is from Mr. Yuvraj. Role of streptomycin injection. I'll tell in detail about that, but streptomycin is typically ototoxic drug which has been used previously. Nowadays we prefer gentamicin because it's typically vestibulotoxic. Basically what we do is take the advantage of its ototoxicity, and they see that there is a chemical ablation of the inner ear, and that is the role of streptomycin. It used to be injected previously in the ear so as that the inner ear function is totally chemically ablated. But now we want the hearing to stay and the vestibular function to go off. That's why we use gentamicin. What are the various ways of using gentamicin, and how it is to be used, and what are the things that I will deal again in the next week. Coming to a definition slide. Okay, I'll come back to. Someone wants the definition. Okay, I'll come back to definition. Okay, by definition, it's the disease. I think the slide I put up, so it'll be easier for you to understand and note it down. Each and every word is important. It is a disease of membranous inner ear, not of the bony or osseous inner ear, but of the membranous inner ear. There is a spontaneous attacks of vertigo. That means the attack are without any stimulating factors, and there is associated with typical fluctuating. That means sometimes it's normal, sometimes it's abnormal. Sort of sensory hearing loss. It is not conductive, it is sensory loss. And of course, it is associated with the three symptoms, basically the hearing loss, tinnitus, and oral fullness. vertigo, tinnitus, and deafness, hearing loss. Oral fullness is usually present with this. I hope this will take care of the definition as such. Again, any more questions? I think there are no more interaction or any more questions here now.
Yeah, Dr. Nitin, I think that were the only questions. And the candidates, I just wanted to say that vertigo is one of the very common complaints that we get in
Yeah,
our
true, madam.
patients in our clinical practice.
Yeah, true.
And so multifactorial that the proper diagnosis is very vital to the treatment, and
Very much so.
often
Yeah. Mm.
difficult to diagnose these patients, and we just end up symptomatically treating them. But Meniere's disease is one of the important causes of this vertigo as a symptom, and if we can diagnose it properly, then the management becomes much easier.
Yeah, yeah, true. Very much true, madam. Well, very well put.
Yeah, yeah. So I think if there are no more questions, we can close the topic for today.
Yeah, sure. Then we'll meet next time and we'll deal with
Uh,
the remaining part of the topic as such. Hmm?
Yeah, thank you very much, Professor Dr. Nitin, for the presentation, and thank you very much, Professor Dr. Nilma Gupta, for joining us, and thank you, trainees, for joining us.
Yeah, thank you, one and all.
And I would request candidates or trainees on this platform to come forward for case presentations. We do keep case presentations, and we can have an interactive discussion on the case presentations. So Dr. Navneet coordinates it so well. If you would volunteer, then we can uh, gradually take up your names and do case presentations.